This review is over Chapter 14, Eating Disorders. American culture has become preoccupied with food, eating, weight, and fitness in order to be thin, and has affected the way we view our bodies today. It's hard to believe that eating disorders are a legitimate mental health concern. The idea that someone is unable to eat or stop eating is hard to understand. Normally, we eat food as a way to provide nourishment to the body, but for some, it is a totally different experience. Instead, it is a way of controlling a life that is totally out of control. Historically, society and culture has influenced what is desired in a female body. In the United States society, thinness is associated with attractiveness, success, and happiness, which is a contributing factor for eating disorders. Culture also influences eating disorders. Women are preoccupied with their body, results from cultural ideas of thinness, and that their identity and self-esteem depend on physical appearance. Here are a few pictures that show how size has been influenced throughout history. In the early 1800s, plump was a desired look. Then in the 50s, women who were a size 14 were considered to be the perfect size. Then around the early 70s came the Twiggy look, which was the start of the size 0 to 2 and has moved into the 21st century. In reality, size 10 to 14 is a true picture of the size of the average woman. Some commercials have now begun to use the true size of the average woman for advertisement. Dove was one of the first to do this. This trend may aid in correcting what is expected from society. The only two eating disorders that I'm going to talk about is anorexia nervosa and bulimia nervosa. These are the two that you will be responsible for. Anorexia nervosa is characterized by a refusal to maintain a minimally normal weight and an intense fear of gaining weight. Bulimia nervosa is characterized by repeated episodes of binge eating, followed by inappropriate behaviors of self-induced vomiting, fasting, excessive exercise, and misuse of laxatives and diuretics. Depression is usually coexistent with bulimia. These two disorders are not limited to women, but they are more prevalent in women. First, we're going to look at the clinical presentation of anorexia nervosa. There are some clinical presentations that are similar between both anorexia and bulimia. These are specific to anorexia. Looking at the objective data on this slide, objectively preoccupation with food, you will see in these clients, refusal to eat, weight loss, which is usually greater than 15%, withdrawing to other rooms to be alone, avoiding family and friends, participating in rigid exercise programs. They're usually highly anxious people. They may have signs of bradycardia, hypothermia, hypotension, and metabolic changes. These result from electrolyte imbalances. Decreased bone density is usually caused by estrogen deficiency. Lanugo, which is caused by the starvation. Cold extremities, they will have peripheral edema, which is caused by hypoalbuminemia, and refeeding. Refeeding, this is a syndrome consisting of metabolic disturbances. This occurs as a result of reinstating nutrition to the starved patient. There is a sudden shift of fat to carbohydrate metabolism. Therefore, it must be done slowly to prevent serious problems, such as the peripheral edema. They will also have amenorrhea, which is also due to hormonal changes. Subjectively, they will report terror of gaining weight. They know that it only takes 200 calories to stop hunger pains. So they have learned to only take in enough food to stop those pains. Other signs subjectively are views of themselves as fat at any weight they may be at. They have feelings of depression. They judge themselves as low self-worth, and they're usually unable to relax. This is what anorexia nervosa looks like. But when they look into the mirror, all they see is fat. Interventions for anorexia nervosa. Some of these interventions listed here are for inpatient monitoring, and some are also for outpatient monitoring. Nursing care for those with anorexia nervosa is aimed at restoring nutritional balance first. Then it is placed on helping the client gain control over their life situations in other ways than inappropriate eating behaviors. First and foremost is close monitoring of the patient or client's INOs to include weight and vital signs. They need to gain weight, but they should not gain weight too quickly. Vigilance 30 to 60 minutes after eating to ensure that they do not go and purge. We need to teach relaxation prior to eating. Enforce a behavior modification plan. Positive reinforcement for weight gain helps them with self-esteem. Limit setting and consistency. By limit setting and being consistent, they don't manipulate the nurse. Close monitoring of all trips to the bathroom after eating is very important. Counseling should be provided to address their self-esteem, feelings of lack of control, their emotions, and their anxiety. Client and family education is also very important. The family needs to know what the symptoms of anorexia nervosa are. They need to know the nature of the illness and what constitutes obesity. Causes of eating disorders should also be explained to family, and the effects of the illness or condition on the body. Continuing with interventions, be sure and review your text for criteria with medical and psychiatric conditions that warrants hospitalization. The family has information about the disease and knows where to get support. This is up to us as nurses to make sure they have this information. The client is amenable to receiving or compliant with appropriate therapeutic modalities. They have family counseling that has been at least offered. This is to provide support and to identify any issues that may be contributing to the client's eating disorders. We need to monitor appropriate blood work. The family and client also need further teaching, education on psychopharmacology to make sure they understand the medications that the client is taking. The client and family desire to participate in support groups. There are individual family therapies, and we also need to make sure they have referrals to support groups. If they have not received these referrals, or do not attend the support groups, we want to try to find out why and realize that it is the nurse's responsibility to make sure family and clients have this information. Psychopharmacology for anorexia nervosa is the SSRIs. Fluoxetine is given to reduce the occurrence of relapse in anorexia nervosa. Olanzapine is given because it helps to improve the mood and it is resistant to weight gain. Also, antidepressants are useful because depression is a comorbid disorder with eating disorders. Clinical presentations of bulimia. Remember, bulimia nervosa is characterized by binging and self-induced vomiting, misuse of laxatives and diuretics. Objectively, we want to see that bulimia clients are usually not thin like the anorexic client. Dental caries and tooth erosion are common, and that is from vomiting and the acidic contents coming into contact with their teeth. Parotid swelling caused by the stress of the vomiting. You may see gastric dilation or rupture, and that's caused from the overstretching of their stomach from binge eating. Calluses, scars on their hands, that is called Russell's sign, and that is from self-induced vomiting. Peripheral edema caused from rebound fluid, especially if diuretics are used. Muscle weakness is caused from electrolyte imbalances. Cardiovascular abnormalities also caused from electrolyte imbalances. With the imbalance of low potassium, it can result in cardiac dysrhythmias and even death. They eat a high-calorie, high-carbohydrate snacks. This helps them curb their appetite. Once they eat a lot of them, then they will purge them. Subjectively, you're going to see they are gravely concerned about their body weight and shape. They report feelings of anxiousness, loneliness, and boredom. And they have problems with interpersonal relationships and problems with their self-concept. Interventions for bulimia nervosa. Again, first is to address life-threatening complications such as gastric rupture, electrolyte imbalances, and cardiac dysrhythmias. Then the general psychiatric manifestations will be addressed. Normalizing eating habits. In inpatient units, normalizing eating habits are structured to interrupt the cycle of binging and then purging. Examine underlying conflict and distorted perceptions. This is to determine if the binging and the purging is for control. Mental therapy, this is anything in the psychiatric community such as safety, physical environment, limit setting, medications, and psychotherapy. It contains or encompasses pretty much everything. Counseling, we need to offer counseling. They need to find out if the disorder is due to a distorted belief held by the client or if it's from a family dysfunction. Psychotherapy addresses the cognitive behavior. Most effective treatment for bulimia targets behaviors responsible for the emotional distress. And then psychopharmacology. The SSRI, fluoxetine, may decrease the cravings for the carbs, which reduces the need for the binge eating and vomiting. Also, antidepressants, because depression is very often a comorbid disorder with bulimia nervosa. These therapeutic communication techniques apply to both anorexia nervosa and bulimia nervosa. Due to most patients being forced into treatment due to concern of their family and friends, it can be really hard for the nurse to develop a therapeutic relationship. That's because many of them believe that the nurse's purpose is to simply make them gain weight. So the nurse is perceived as the enemy and not the ally. Therapeutic communication can help the nurse become the ally. So in providing that therapeutic communication, we need to convey warmth and sincerity. They have to know that we are real and that we really care. We want to listen empathetically without judging. We need to be honest and set appropriate behavioral limits. We need to teach patients about their eating disorders. They need to be able to learn what's going on and start connecting their feelings with reality. Compared with a patient with anorexia, who is restricting food, the patient with bulimia more readily establishes a therapeutic alliance because the eating behaviors are so ego dystonic or against what they want. Therapeutic alliances allows the nurse and other team members to provide counseling that gives useful feedback regarding those distorted beliefs. With bulimia, be aware that the patient is sensitive to the perceptions of others. The patient may feel shame and totally out of control. Therapeutic alliances emphasizes feelings of low self-esteem, unworthiness, and dysphoria. Nurses may suspect dishonesty when the patient does not report binging and or purging. Accepting and having a non-judgmental approach, again, and understanding the subjective experience of the patient will help to build trust. Client education for bulimia nervosa is very similar to that of anorexia nervosa. So for client and family education, we want to correct administration of prescribed medications, teach them what doses they should be getting, how to take them, and side effects that maybe go along with those medications. We want to teach them relaxation techniques, problem-solving skills, and we want to offer and make sure they have resources on support services. And some of these, excuse me, can be Weight Watchers International, Overeaters Anonymous, National Association of Anorexia Nervosa and Associated Disorders, and the American Anorexia Bulimia Association Incorporated. Treatment modalities these apply to both eating disorders. Behavioral modifications are aimed at treating the disorders and restoring nutritional status. We must correct the behaviors before complications such as electrolyte imbalances, cardiac dysrhythmias, dehydration, and other problems occur. Individual therapy helps to identify underlying psychological problems. Family therapy helps to identify negative impacts on the individual who has an eating disorder, possibly from the family. Psychopharmacology, remember SSRIs and antidepressants are important for treatment. This slide shows shared features of anorexia and bulimia. I put this on there for your review. Here are some web resources that can be provided to people with eating disorders.